So, we really know that multiple myeloma is a disease of older adults. So really thinking about what are optimal ways to treat them is an important question. So when we think of treating an older adult with multiple myeloma, really the goal is to induce a deep response and so really control the disease, but at the same time, limit toxicity, limit early mortality, limit early discontinuation rates, and overall improve the patient's quality of life. So I would say in this regards, when we really are looking for effective regimens with limited toxicity when we think of treatment for older adults with multiple myeloma. And I would say, the current standard of care for treating these patients is really a triplet-based regimen. It could either be, daratumumab in combination with lenalidomide or dexamethasone, or bortezomib in combination with lenalidomide and dexamethasone. Now, both of these have been evaluated in phase 3 studies, and particularly, dara-lendex was evaluated in the MAIA study, which showed an efficacy with a median PFS of over 62 months and an overall survival that's going to be expected to be beyond 7 years. So I would say, while triplet regimens really should be the standard of care, there are really important considerations when we treat older adults. And they include, how do we dose these agents? Do we start all 3 drugs together, or do we start 2 and then add in a third? And then how do we dose drugs like immunomodulatory agents? So can we play around with the dosing to really titrate it to minimize side effects, but maintain the disease efficacy? Similarly, we're really learning that probably one of the biggest culprits of side effects is actually dexamethasone. So how can we effectively use dexamethasone upfront for early tumor reduction, but then think of it early reduction of dosing or discontinuation altogether, because we do know that it's associated with side effects. And then lastly, I think, when we talk about treating myeloma patients, and specifically older adult with myeloma, we can't just think of what drugs to use. We really have to think of the supportive care measures as well in place. So prophylaxis for infection, antiviral drugs, and appropriate thrombosis prophylaxis as well if a patient's going to be on an immunomodulatory drug. We need to think of bone health management, and again, be really prompt in responding to any emerging side effects that will really ensure that we're able to maximize the benefit of these therapies and keep our patients on them as long as it's possible to really get the most out of these drugs.